Περιμένουμε και τον κύριο Βλαχόπουλο, ο οποίος έχει έρθει. Ο κύριος Πανταζής, συμπρόεδρος, θα μας μιλήσει από το διαδίκτυο. Πιστεύω να είναι συνδεδεμένος ο κύριος Πανταζής. Και ο κύριος McKenna και εγώ και ο κύριος Βλαχόπουλος θα είμαστε διαζώσεις εδώ. Shall we start?
Yes.
Επειδή λόγω του διακεκριμένου ξένου Προέδρου, καθηγητή κ. McKenna, οι ομιλίες παρακαλώ να γίνουν στα αγγλικά. Όποιος θέλει να μιλήσει και γαλλικά, μιλάει και ο κ. McKenna και εγώ μιλάμε γαλλικά, οπότε μπορείτε σαν εναλλακτική να διαλέξετε τα γαλλικά. In French.
Ισπανικά. Πέτρο, Ισπανικά πες.
Ισπανικά, ναι, μπορούμε την επόμενη φορά. Αλλά θα ξεκινήσουμε λοιπόν με τον κύριο Ζέγκο. Θα μας μιλήσει για το πρώτο περιστατικό. In English, Thomas. Okay. Thomas has excelled himself yesterday when he was in the middle of his talk, switched to English, and he responded in excellent. So he's a very, very smart, clever young cardiologist. Thomas.
Good morning by me. Saturday today, nice weather. Okay, so I'll start with the first case of our Saturday morning. It's a cardiomyopathy case which shows the changing clinical decision pathway in the era of genetic testing and precision medicine. So, I'll talk about a male, 39 years old, who was referred to our cardiomyopathy's outpatient clinic due to multiple premature ventricular contractions. He had already performed the CMR, and our CMR specialists raised the suspicion of underlying cardiomyopathy, so he referred him to us. His symptoms was only palpitations. He had nothing else. He already had started receiving medications like Ramipril and bisoprolol. Here you can see his family tree. He had a father who died at 66 years old due to CA, and his mother and sister were free from medical problems. They didn't receive any medication, and he also had 3 kids. You can see our patient here. Now you can see his ECG. You can see the frequent, very frequent premature ventricular extrasystoles. And you can see that from the left ventricle, you can see the positive V1 lead, and also the inferior axis of the extrasystole is the positive 2, 3, and AVF leads. And also you can see the negative 1 and L. So we have premature ventricular extrasystoles from the base of the left ventricle. A Holter was performed, and we showed 900. Good morning, Professor Efthymiadis. And okay. And we showed 9,500 premature ventricular contractions with 2 non-sustained ventricular tachycardia episodes, one which had 10 systoles and one with 8 systoles. Now you can see his echo. We can see nothing major here, just a mild LV dilatation at about 6 centimeters. The ejection fraction, we could say it's normal or near normal, about 50%. Maybe we have the suspicion of a mild hypokinesia of the interventricular septum. And this is the CMR that the patient was referred to us that raised the suspicion of cardiomyopathy. And you better can see the dizziness of the interventricular septums, especially from the short axis. The ejection fraction was reported by our CMR specialists at about 48%. Here, 50 near normal, 48 to 50%. And here you can see the LGE, the late gadolinium enhancement, which you can see, I don't know if you can see it correctly, it's a limited mid-wall fibrosis of the interventricular septum. This is the sign which raised the suspicion to our CMR specialist, Professor Karamitsos. So, first, we performed genetic testing, and we were awaiting for the results. In the meantime, the patient visited an arrhythmologist, and he underwent a PVC's ablation. And when he was followed up, reduction of PVCs was observed, significant reduction of PVCs, without any non-sustained ventricular tachycardia episodes. However, later we received the results of the genetic testing, and surprisingly we had two pathogenic mutations. One missense mutation of the MIL2, which we know it's a gene which is associated with hypertrophic cardiomyopathy. Nothing that reminds us of our patient, and a frameshift mutation of lamin, which may be the cause of the cardiac phenotype of the patient. So we can see the family tree. We have our proband, which has the frameshift mutation of lamin, and now we went to clinically investigate his mother. The mother was 74 years old, asymptomatic, without receiving any specific medication. And we can see her ECG. The only thing that we can see here, I think, there are low voltages in the lip leads. And first...
Can you use the pointer so you can show on the
yes.
screen?
You can see the low voltages. Excuse me. Better. The low voltages of the lymph leads, and there is a first degree AV block, about 210 milliseconds. Here you can see the echo of the mother, which, sorry for the quality of the echocardiographic window was very difficult, but anyone can see that it is an HCM phenotype with maximal wall thickness of the interventricular septum about 13 to 14 millimeters, and we can observe the chordal sum here, which creates an obstruction. You can see the late peaking signal in Doppler cardiography, however, without having any hemodynamically significant obstruction observed. So here, we may have expected to find the MIL2 mutation due to the HCM phenotype. However, the genetic testing showed us that the patient had the same frameshift mutation of lamin. And we are awaiting for her Holter, and we will proceed to further exams, CMR, and so on. His sister, 37 years old, asymptomatic. You can see her ECG. Nothing major, okay, normal ECG, I think. Her echo is normal, also nothing major. And the genetic testing showed us that she had the missense mutation in MIL2. By herself, she performed the CMR to our CMR specialist, which was also normal. So here we don't have any phenotype and the missense MIL2 mutation. So to return back to the family tree, we have the proband which has the frameshift lamin mutation, the missense MIL2, his sister no phenotype with MIL2 mutation, and his mother with HCM phenotype with frame and AV, first degree AV block, however, very important, and the frameshift lamin mutation. What we should do next? First, the most challenging thing is to risk stratify the proband for the most important event in lamin mutations for sudden cardiac death. And we have this data. We have an ejection fraction from the CMR to 48%. We have non-sustained VT episodes before the ablation, and presence of limited but still present late gadolinium enhancement in the interventricular septum. Here you can see the lamin risk VTA calculator proposed by the ESC guidelines, which shows us 25.5% of risk to die for our patient to die suddenly the next 5 years. It's a quite increased score for our patients. But before I continue for the patient, let me say some things about lamin for the audience. Lamin is a protein of the nuclear envelope, okay, which causes cardiomyopathy with three main mechanisms. First, it contributes to the structural integrity of the nucleus, and so a disrupted protein results in altered structure of the nucleus and altered structure of the cardiomyocyte, and which leads to cardiomyopathy. The second mechanism is the mechanotransduction hypothesis, in which the lamin that acts as a part of the LINC complex confers resistance to any mechanical outside stress to the myocyte. So, if we have a deficiency in lamin protein and deficiency in the LINC complex, which also helps to the link between the nuclear envelope and the cytoplasm, we have a sensitive structure of the myocyte and cardiomyopathy. And the third mechanism is that lamin acts as a regulator of the transcription factors and directly binds also the chromatin. And all these mechanisms, these three mechanisms, lead to dilated cardiomyopathy, the first manifestation of the disease, we know for lamin, cardiac conduction system disease, atrial and ventricular arrhythmias, and sudden cardiac death. What do we know for lamin cardiomyopathy? First, we know that 6% of familial DCM-KT cases are caused by truncating lamin mutations. Truncating lamin mutations have 100% probable penetrance, and over 90% penetrance happens until the age of 40. We have 100% penetrance until the age of 60 years old. What that means? It means that a patient with lamin mutation will develop cardiomyopathy for sure during his life. Conduction disturbances and ventricular arrhythmias precede LV dysfunction for many years. Over 60% of patients identified with conduction disturbances and arrhythmias usually do not have LV dysfunction. 95% of family members with cardiac phenotype have only conduction or arrhythmic phenotype without dilated cardiomyopathy. And about 50% of the genotype positive patients, regardless of the underlying cardiac phenotype, have limited septal LGE. Here you can see that the development of cardiac phenotype is the same both in probants and positive family members. And more importantly, when we have asymptomatic genotype positive family members without any phenotype, and when I mean phenotype, I mean not only LV dysfunction, structural disease, but also conduction disturbances and ventricular arrhythmias. Lamin genotype positive family members, more than half of them in a few months will develop the disease. Here you can see the diagram that ventricular arrhythmias and atrial arrhythmias and conduction disturbances precede LV dysfunction for about 7 years, a time which is statistically significant. We are sure that lamin are not benign mutations, are malignant mutations, and over 80% of the patients will develop heart failure, over 25% of the patients will develop end-stage heart failure, and over 20% will eventually die. And as you can see, this is the largest study with genotype familial DCM patients, showed us that lamin nuclear envelope protein mutations with the most important representative lamin mutations have worse prognosis with respect to major adverse cardiovascular events, with respect to end-stage heart failure, malignant ventricular arrhythmias, and they also had worse left ventricular reverse remodeling, excluding only desmosomal mutations and desmoplakin, which was also very low, the reverse remodel of the desmosomal mutations. Here you can see a meta-analysis of our team. You can see that our results are important. Excuse me. Patients with lamin compared to patients without lamin mutations had 5-fold higher probability of developing any major adverse cardiovascular event. Moreover, lamin truncating mutation conferred a threefold increased risk for ventricular arrhythmias, malignant ventricular arrhythmias, and a fourfold increased risk for heart failure events. With direct gene-to-gene comparison, lamin variant was worse than titin truncating titin mutations in all the endpoints. However, the risk was not significantly different from desmosomal variants and desmoplakin. Now, with respect to extrasystoles, you can see that lamin variants mainly has the extrasystoles has the morphology that of the extrasystoles our patient had. That is, from the left ventricle with positive V1 and negative 1 and L. Sorry for the pointer. L and 1, and with a positive inferior axis. This is a multicenter study that also showed us that ventricular tachycardia originated from the basal left ventricle, particularly the septum, but also basal inferior wall and subaortic mitral continuity. This study also showed us that catheter ablation possibly has no role in lamin cardiomyopathy because it was associated with poor outcomes, high rate of arrhythmia recurrence, over 90% the first year follow-up, and progression to end-stage heart failure and high mortality. Now, the most important risk factor for SCD. We know from a decade ago that these were the risk factors for lamin cardiomyopathy: non-sustained ventricular tachycardia, ejection fraction below 45%, male sex, and non-missense variants. It was proposed that if a patient had two of these risk factors, an ICD would be suggested. However, nowadays we know that there are more factors contributing to the risk of lamin cardiomyopathy, conduction system disease, and the most important I should note is the presence of late gadolinium enhancement, which bears an 100% negative predictive value. What this means, that if a patient has no late gadolinium enhancement, his risk for dying suddenly is quite low. And now to our guidelines. From 2023 guidelines for cardiomyopathy, we know that an ICD should be considered in patients with DCM or non-dilated left ventricular cardiomyopathy with a genotype associated with high SCD risk like lamin, ejection fraction over 35%, and presence of additional risk factors which are syncope and LGE presence, not extent, only presence. Also, the same guidelines propose to calculate this risk that we calculated for our patient, and from the VA guidelines, we know with a 2A indication that if the risk score is over 10% in the presence of non-sustained ventricular tachycardia or ejection fraction below 50% or AV conduction delay, an ICD should be considered. Also, in patients with LVEF below 50%, the two additional risk factors, which are syncope, LGE on CMR, inducible SMVT at PES, pathogenic mutations in lamin, phospholamban, filamin, or ABM20. A 2A indication exists for ICD implantation. Returning to our patients, having all these data, an ICD, there is a 2A indication that an ICD should be considered, but we should think that we talk about a young patient, fully asymptomatic after the ablation. After the ablation, we don't have any non-sustained ventricular tachycardia. However, we know that the ablation has no role in lamin cardiomyopathy. We are in the process of discussing what to do here.
What is the risk without non-sustained?
It's over 10%, it's 15%. So, lamin cardiomyopathy is highly heterogeneous with high penetrance. Lamin mutations we know are associated with worse prognosis, both heart failure and SCD. And risk stratification process for lamin cardiomyopathy remains challenging. Thank you very much.
You have excelled yourself, amazing case. I don't think that there are many centers in the world, Thomas and Giorgos, that they can study in such detail the families of cardiomyopathies. Andonis, you work at the Brompton. Do you really study your own patients in such a fantastic and comprehensive way?
Well, the quick answer is yes. But the question, I suppose, is not whether we at the Brompton or in other places, in other tertiary centers, there is in-depth study of the cardiomyopathy patients and families. The question is if this can be applied to all cardiology centers to some extent, because then we create a postcode lottery and there is no equity of access to the patient. So if someone lives near Thessaloniki or near the Brompton may have this type of care, but if they live somewhere else, they don't. So I think the big challenge is not what the specialist centers do, which I'm happy to say that they probably do very good work. The big challenge is how we can actually get this out to the broader community and give the patients with cardiomyopathy and their families the appropriate care.
Bill.
Yeah, I mean, beautiful case presentation, and a couple of messages. One is risk stratification in all the cardiomyopathies until recently was this risk factor or that risk factor. What we have with Lamin, we started off with poor ejection fraction deletion in Lamin or non-missense mutation and low ejection fraction and arrhythmia as the risk model. We've now integrated that into a much larger risk profile, and that's what we need to be doing with a greater computer capacity and clinical capacity to evaluate, which is very nicely done. Interesting, if all the risk factors and that are listed, two very important are gender and age, and that didn't come out. And the Health and Code database, and I don't remember exactly, but there's roughly 1,000 gene-positive Lamin non-missense mutations. And the curve goes along until you're about 35, male and female, and then the curve drops for males. And the males start dying suddenly in their 40s. So you take these risk profiles, and if the patient is the son and he's age 18, you don't put an ICD in. His risk changes dramatically sometime in the middle decades. Now this patient is middle decades, and there's no question for me he needs an ICD. But age and gender are very important components, and the curve is different for females. So that hasn't come out in all these Hauga and all these registries. And a third, when you were presenting, myosin light chain is actually, and I don't know that particular mutation, that missense, but myosin light chain is associated with a particularly poor hypertrophic cardiomyopathy, heart failure, need for transplant in your 30s, very bad. And I thought, aha, the mother's going to have the light chain hokum, and the son has and it was exactly the opposite. So how that light chain, what's going on in the mother is very interesting, because she looks like a mild female late onset Lamin, and yet, which is what she had, but what the light chain is doing in there, maybe just a bystander, may not be doing anything. But usually in every disease related to cardiomyopathy, if you have a second variant, even if it's not disease causing in and of itself, if that second variant is not seen in the normal population, it usually has some component of expression, and whether that's C protein in HOCM or any. So that second variant is likely to be important, but trying to work out what it's doing is of interest.
We're continuing the investigations for the family. We'll present it next year.
It'd be very interesting to pull it together, but making sure you check. One of the things that happens, if you do a gene, you find the gene Lamin in the patient, and then you check the family. But you need to check the family for all the genes, not just Lamin, because you'll find other genes. And that's there's the pediatric registry in hypertrophic, and they actually is the first time anybody systematically looked for other genes. And your prognosis, if you have a second variant with MYBPC3, is much, much worse. You're actually MYBPC deletion all by itself is not a major deal. But when there's a second variant, that's sudden death, heart failure. Anyway, very, very nice presentation. And
thank you, Professor.
But I think he needs an ICD.
George, yours.
We are a little late. I would like to ask the chairs and What do you think for the patient? To put an ICD or no? Or discussion?
No, I think Professor McKenna answered yes, ICD. I think in view of the time and this discussion may go on all morning, I'm sure there is so much to say. Respecting the time, we have to proceed to the next presentation. Thomas, excellent. We will.